Welcome to the Urgent Care Association's Solutions on Demand webinar brought to you by HealthTrack RX. Today we will discuss the role of rapid multiplex PCR to optimize clinical decision-making when evaluating infectious disease complaints in the outpatient setting and really focused on the heat of the summer. Change the diagnostic challenges that you'll see in your clinic during these summertime months. And to work through these cases, we're joined by two experts in molecular infectious disease diagnostics and urgent care medicine. I'm your moderator, Ben Favre. Dr. Janie French, who is a microbiologist and medical science liaison for HealthTracks. Dr. Stephen Goldberg, who is an urgent care practitioner at University of Louisville, is also the chief medical officer for HealthTrack RX. With that, we have our third case. This is a 7-year-old that presents with the complaint of excessive dandruff and itchy scalp. The condition comes and goes, no relevant medical history. The young boy loves video games and goes outside infrequently, especially during the heat of the summer, refuses to bathe, and lives in his bedroom with 3 other siblings. The home does not have air conditioning, which is really hard this time of year. Dr. Goldberg, what are your thoughts here?
While cases like this aren't necessarily common complaints in an urgent center setting, they can provide some diagnostic challenges. There are several conditions that can cause an itchy scalp: dandruff, seborrheic dermatitis, psoriasis, eczema, and you also have to consider head lice and scabies, and certainly Tinea capitis, a fungal infection. Now, if you've been practicing many years, you likely have been able to see individual examples of each condition, and you can make a clinical diagnosis. But if you're earlier in your career, and even for me today, it still can sometimes be challenging. So if you're not confident on your empiric diagnosis, a diagnostic test can be helpful.
So when the patient comes in, Dr. Goldberg, you see small patches of alopecia, some dry scaly rashes, and some patches of redness. Any additional thoughts here? We're kind of taking this?
We frankly gave some features here that suggested a single diagnosis in those that I listed. This child is a setup for that circumstance because of some of the features we mentioned. Not getting outside to get sunlight or drying of skin, disinclined to bathe, so puts them at risk for certain types of infection. Crowded conditions and lack of air conditioning also contribute to that case.
Thank you. So Janie, walk us through from a microbiologist perspective, what are you thinking and how would you proceed to diagnose this patient?
If we're concerned about Tinea capitis, there are 2 primary fungal species causing these cases. These would be Trichophyton tonsurans and Microsporum canis. Really, when we think about diagnostic techniques available, we want to be able to diagnose these 2 particular fungal species. And while differentiating them is not strictly necessary for treatment, their differences do make them challenging to diagnose. And it's often recommended to get a positive test result for Tinea cases because there may be non-infectious causes that result in similar symptoms, and systemic antifungals aren't always required. And because systemic antifungal treatments can last 4 to 8 weeks, adherence can be low. So if treatment fails and you don't have a diagnostic test result, it's hard to know, is it because there was low adherence to the treatment, or is it because you need to consider an alternate diagnosis? So a diagnostic test result can help you be definitive about whether or not it's an infectious cause. When we think about the diagnostic techniques available, culture can be an option, but it may take several days to weeks to get a result depending on how fast the fungal species is growing. There are also some in-house testing options available. A provider could do a KOH prep, but these often lack sensitivity for these fungal species. A clinic may have a Woods lamp available in the clinic, which is just a UV light, and this can be helpful for identifying Microsporum species because Microsporum fluoresces under UV light, but Trichophyton does not. So while the Woods lamp would allow you to rule out Microsporum, it wouldn't allow you to rule out Trichophyton infection. Another option then would maybe be the use of PCR, which has the advantage of being rapid and capable of identifying both fungal species to get an answer for the patient.
So Janie, kind of what I hear you saying there is clinically actionable can be that treat, don't treat decision being as important as I need to write a prescription for a patient like this. Very interesting. So Dr. Goldberg, walk us through your medical decision-making and treatment plan for this patient, please.
We have to decide if this is something that we think is contained to the superficial scalp, or we think there's risk of a more generalized infection. If we think there's a more generalized infection risk, then down the road we might have to think about oral antifungals. If we think it's confined to the scalp, we likely could get some success with tar compound shampoos and etc. Now, going back, the differential is kind of broad, but based on what the clinical situation set up, this patient was more likely to be having a tinea diagnosis than another diagnosis. So, based on exam, if it looked constrained, I would be inclined to get a sample for definitive diagnosis to make sure if I needed to escalate treatment, I'd have a match between the antifungal and the pathogen. But if it's confined and limited, I'd likely start with a topical antifungal shampoo while waiting for confirmation of a specific infectious agent.
Thank you. So with that, we have our next audience survey question. In this scenario, what would you use to decide if this is tinea? No test, I'd treat empirically. Culture, KOH prep or Woods lamp, or clinically actionable PCR. And our results are coming in. We have a smattering of several answers so far. Pretty interesting. All right, so Janie, Stephen, y'all are seeing the results here. We kind of have a mixed bag. Clinical actionable PCR right at 38%, then 25% for the KOH prep, Woods lamp, or no empiric treatment. Stephen, what are your thoughts on those results?
I think people have training and ongoing education on different approach to different clinical problems. I also think they have different resources within their practice care setting, different availability or not of different types of point of care testing. So I think as Janie outlined, several of these point of care options have utility with some limitations or some benefits. So I think it's all reasonable. In the setting where I work in, we don't have access to KOH prep or Woods lamp. And again, if you have high confidence in your ability to differentiate among several different itchy type conditions, then empiric treatment might be reasonable. But if there's doubt, especially with concern of risk to follow-up, then getting a diagnosis specific would be really helpful.
Thank you. Jane, anything to add?
Exactly like Dr. Goldberg said, if you've seen cases like this and you're comfortable differentiating between different causes of these patient symptoms, it may not be necessary to test unless there's treatment failure and you're concerned that maybe the initial diagnosis was incorrect. But beyond that, it becomes about what tests have you used before and are comfortable using and what's available in your clinic.
Thank you. Dr. Goldberg, any final thoughts that you want to share with our audience before we get to questions?
Well, 3 comments, Ben. It's always fun to have a microbiologist with you to offer the larger context when evaluating patients, but we don't have that opportunity regularly, right? So we've got humility about that. The second is infectious disease are a common problem in the urgent care setting. I see it regularly. I saw it yesterday in the clinic. And then finally, you really want to get it right, and getting it right involves knowing what types of infections you're more likely to see in the summer versus other time during the year.
Eliminating that clinical confusion and getting the patient comfortable with what you're doing seems like it's really important. Jenny, what about from a microbiologist perspective? Anything to close on?
People are generally really familiar with the seasonality of respiratory infections occurring at higher rates in the fall and winter. But there are also considerations for summertime infections because environmental changes like increased UV exposure causing higher rates of shingles episodes or increased temperature and humidity increasing fungal infection rates are common. And there can also be behavioral changes. People are going to go to community pools where there may be exposure to waterborne illnesses, or there may be increased exposure to environmental toxins like poison ivy. Thinking about the risk factors of different infections and the prevalence in the community will be helpful in diagnosing some of these summertime infections.
With that, we will end. Thank you for joining us for this Urgent Care Rounds brought to you by the Urgent Care Association Solutions webinar and Health Track RX.